Good afternoon. I'm extremely happy and proud to welcome all of you for today's special lecture, Implementation of District Mental Health Program, DMHP in India. I have the great honor for delivering this lecture. We have Dr. Alok Mathur, Additional DGG, Ministry of Health and Family Welfare, Government of India, has kindly agreed to deliver the keynote address. And today we are going to listen to many states who are implementing the district mental health program. Very especially, I have Dr. Rajani Parthasarathi, the Deputy Director Mental Health Division of Government of Karnataka, who is implementing the district mental health program in the state. Almost all the districts of the Government of Karnataka, we have the DMHP program very actively. I have the honor, we have Dr. Rajani Parthasarathi. Along with this, I welcome Dr. Rajani Parthasarathi. I also, other members, they will be online. We will have Dr. Alothur Renita Rai Devi from Manipur, Dr. Ajay Chauhan from Gujarat, Dr. Sumi Jain from Chhattisgarh, Dr. Sunil Pandey from Uttar Pradesh. They all will be sharing their field level experience of implementing the district mental health program in the country. For sharing this session, I have the great honor. We have our beloved professor, Professor Mohan K. Isaac, our professor of psychiatry and former HOD of the department of the oldest and prestigious department of psychiatry, not only in the country, not only in Asia, in the whole world. I have the honor, we have Professor Mohan K. Isaac, who is also functioning as a visiting professor of our NIMHANS and empowering all of us, not only in the field of mental health, in the entire field of the allied mental health services. I have the honor, I welcome Professor Mohan K. Isaac for chairing this session on behalf of the department. This department and along with Professor Dr. Mohan K. Isaac, I also have the privilege, Dr. K. Sekhar, our professor of psychiatric social work, also will be the co-chair for this program, and Professor Sekhar also will be online, and he has some Government of India assignment today. He will also be joining us, and he will be also co-chair the session along with the Professor Mohan K. Isaac. And I'm extremely happy this program is jointly organized by the Department of Psychiatric Social Work at NIMHANS. This program is organized in collaboration with the Telemedicine Center and the Community Psychiatry Unit of the Department of Psychiatry. I have the honor, we have all the HODs of the Department of Psychiatry, Clinical Psychology, Psychiatric Social Work, Psychiatric Nursing, Mental Health Education, and all our allied department, senior faculty members and heads of the departments, and all the members who are actively involved in the services of NIMHANS are available today with us. I also have the honor, our Professor Dr. G. Gururaj, Senior Professor of Epidemiology and our Director, will be joining us very shortly. He is in another meeting. He will be joining maybe after 5-10 minutes. I will also have the honor to have Dr. Shankar Narayan Rao, our Registrar of NIMHANS. Both our Director and Registrar, they will be joining around 3:30. Professor Pratima Murthy will be joining through online. Dr. Pratima Murthy is a head of the Department of Psychiatry and the major collaborator and the person who is an architect of this entire program. Dr. Janardhan Reddy, head of the department and in charge HOD of the Department of Psychiatry, will be joining us. Dr. B.M. Suresh, head of Telemedicine Unit. Dr. C. Naveen Kumar, head of Community Psychiatry. All our senior faculty members, very especially I have the honor, I have Professor C.R. Chandrasekhar, our former senior professor of psychiatry and director and founder of the Samadhana Counseling Center, and we all have the privilege, Professor CRC, has done tremendous work in the field of community mental health along with Professor Mohan K. Isaac, and I have the honor Professor C.R. Chandrasekhar is with us. I'm also extremely happy to invite our own beloved professors, Professor Dr. I.A. Sharif, the founder professor of the Department of Psychiatric Social Work, who was heading the department for more than 20 years and who just received his DLit from the Tumkur University 2 days before. I have the honor, I have Professor I.A. Sharif, I have Professor M. Ranganathan, Professor of Psychiatric Social Work and founder of the Family Fellowship Society for Psychosocial Rehabilitation. And Professor Ranganathan is consistently working in the area of rehabilitation for the welfare of persons and family members with the chronic mental disorders. I have the honor. I welcome Professor Ranganathan. I also welcome Professor Dr. D. Muralidhar, our Professor of Psychiatric Social Work and our former HOD of the department, for all his active support and encouragement of all the activities. I welcome all the professors. I have Professor Trimurthy, our former HOD, all the faculty members from the Department of Psychiatric Social Work, Psychiatry, Clinical Psychology, Psychiatric Nursing, Mental Health Education, and all the members who are directly and indirectly helped us to initiate this program. With these few words, I welcome Professor Dr. Mohan K. Isaac to lead the session and chair the session today and conduct the entire scientific program. I welcome you, sir, once again, sir. Thank you very much. Yes, sir.
Okay. Okay. Thank you very much, Dr. Pandian, for that kind welcome. It's indeed a great privilege for me to be chairing this session on implementation of the National Mental Health Program, particularly the District Mental Health Program in India. It is good to note that today's program, we have representatives from all across the country. Somebody from the south, Dr. Rajani, talking about Karnataka. Then we have representatives from the west of the country, Dr. Ajay Chavan, who will talk about Gujarat. And then we have the north of the country, Chhattisgarh, and the northeast of the country, east of the country from Manipur. So we always say that India is a very heterogeneous country with different kinds of background, different kinds of people. And today, when we are reviewing the not really reviewing, but looking at the current status of the implementation of the district mental health program across the country, it is not just one person, but it is 4 people from 4 states representing the south, the west, the north, and the east who will be talking. But then, of course, to give us a national perspective, somebody who is sitting in Delhi at the Ministry of Health and Family Welfare, who is particularly in charge of, who is the focal point for the implementation of the district mental health program, is going to be talking to us, giving us a keynote address. And that is Dr. Alok Mathur. Alok Mathur is currently the additional Deputy Director General working at the Directorate General of Health Services in the Ministry of Health and Family Welfare, Government of India. He is somebody who has been in charge of looking after the broad area of non-communicable diseases. Currently, his responsibilities are the National Mental Health Program and the National Program for Palliative Care at the Directorate. But immediately prior to this, he was looking after the Cancer Control Program and the Tobacco Control Program. So Dr. Alok Mathur is a physician with additional training in public health. He is in a way a veteran. He has been in the Directorate for a number of years. At least I remember seeing him more than a decade and a half, representing the Directorate General of Health Services, Government of India. And it is very good that somebody who is as experienced as Dr. Alok Mathur is in charge of the mental health program. So he will be the first speaker this afternoon. He is going to give us the keynote address about the overall perspectives on the implementation of the National Mental Health Program. Now, he will be talking to us sitting in Delhi, probably in Nirman Bhavan. And what happens is when you are in Delhi, you are called here and there for various meetings, called by the minister, by the secretary. And Dr. Mathur may have to leave a little later after 3:30. And so without wasting much time, may I invite Dr. Alok Mathur to give his keynote address. Ladies and gentlemen, please welcome Dr. Alok Mathur, Additional Deputy Director General, DGHS, Government of India. Dr. Mathur, please.
Thank you very much, sir. On behalf of the Ministry and the Government of India, I welcome you to India, Bangalore, NIMHANS, and to this workshop here, webinar here. We are fortunate to have you here amongst us. And, you know, everybody knows you are a veteran in the field of psychiatry, and you have earned a good name, not only in India, but internationally also. Thank you very much, sir. As you know, National Mental Health Program was implemented way back in 1982. I think Dr. Mohan Isaac will highlight on the history and evolution of National Mental Health Program over the last few decades. But it was implemented way back in 1982, and the District Mental Health Program, which is a key component of National Mental Health Program, that was included in the umbrella of National Health Program in the year 1996. And since then, we have been able to cover till date almost all the districts under District Mental Health Program. This is a very, I'm happy to share this information with you. We have representations from 5 states here. And in fact, when I was asked to name the states, which may be included in today's webinar, I was thinking that, which state should I name, because all the states are doing so wonderfully well. So I thought of giving the names from, each region representing our great country. So under District Mental Health Program, as I said, we have been able to cover almost all the districts. And again, I am happy to share with you this information that we have now percolated down to the taluk or CHC level and then the PHC level. Many states have come forward under their, they have proposed under their PIP proposals that they would like to start, the psychiatry services at taluk hospital levels, then at CHC levels. And, Dr. Rajni is here. She is implementing District Mental Health Program at taluk levels also. Dr. Ajay is here. He is implementing this program in urban areas also. So many states have come forward. Recently I was going through Maharashtra PIP proposal 2 days back, and the Maharashtra has additionally proposed the support for 2 municipalities, 2 urban areas in Mumbai. So it's heartening to note that the DMHP is not only spreading or expanding in the at the district level, but it has also gone down to taluk hospital level or the CHC level and in urban areas also. So it's very heartening to know that. And under DMHP only, under this umbrella of District Mental Health Program, we have been able to do a lot of innovation work also. This is a new thing that I have noticed. Karnataka state had e-Manas. The e-Manas is a software platform that was developed by Karnataka state by getting support from the Government of India, NHM, and the program for developing e-Manas. And this is a very good software platform. And as I said, I was going through Maharashtra proposal recently, and they had asked support for developing a similar kind of software. And they had thanked in their proposal Government of Karnataka for developing this software platform, and they were asking the support so that they can further have a similar kind of software platform in support of NIMHANS, IIIT Bangalore, and Government of Karnataka. So this is also reflecting a kind of coordination, cooperation amongst the states, different states. A number of state program officers are in communication with each other. They are inspiring each other. We have a common WhatsApp group. They post the, the photographs of their activities that are being conducted under the program. So that way it gives a very positive kind of atmosphere, not only in the WhatsApp group, but overall also. Whenever we meet physically, they feel very much at home. And I'm glad that I also, feel them as my family. So this is such a wonderful atmosphere that we are having here, that and I'm happy that DMHP is growing. And I think I have a I'm very sorry that I have a meeting at 3:30, so I might have to leave immediately. But I promise you that as soon as it is over, I'll come back and join you back. In the meanwhile, I introduce you to Dr. Megha. Dr. Megha is sitting with me. She has recently joined this National Mental Health Program. She has replaced Dr. Indu Grewal. And in the meanwhile, she will sit and attend this webinar. And as soon as I return back, I will also join. Thank you so much. Thank you.
Okay. Thank you very much, Dr. Alok Mathur, for giving us that broad overview. It's a pity that he had to leave, but then he has promised us that he will come back. Essentially, he has said 3 or 4 things. Firstly, the district mental health program is now reached almost all the districts of the country, which is very heartening to note. And most of the states are doing very well. Secondly, there has been both an upward and a downward extension of the program. In states such as Karnataka, it has gone down from the district to the taluka and the community health center level. And in large metropolis, the philosophy of delivering mental health care using the district mental health program model has gone into the urban metropolis. And in Maharashtra, they have put up proposals for implementing this care program in 2 large areas of the large urban metropolis of Mumbai. So it's a expansion into the urban areas. So it's all very heartening to note that this is taking ahead. And he also did mention about the e-Manas program of the Karnataka. Now what we are going to do is that we will listen from the speakers from Karnataka, Gujarat, Chhattisgarh, and Manipur. Karnataka is one of the leaders in the implementation of the National Mental Health Program. It was in the district of Bellary that the prototype model was first developed way back in the 1980s, mid-1980s. And Karnataka, I believe, has taken a steady lead in implementing the program in various ways. Before I invite Dr. Rajani to come up and make the presentation, may I request all the participants who have any kind of doubts or comments to put them up in the chat box. There, here in the secretariat who is organizing, there is somebody who is looking at all the chats and questions which come up and the comments. It will all be collated. And if there are any specific questions to be answered by any of the speakers, that will be put to them at the end of all the speakers. So, as I mentioned, we begin the journey about the implementation of National Mental Health Program from South. And we start with Karnataka. And the person who is going to make the presentation from Karnataka is Dr. Rajani. Dr. Rajani is currently the Deputy Director in charge of mental health at the Directorate of Health and Family Welfare Services. She is a trained psychiatrist. She joined the Department of Health and Family Welfare as a psychiatrist. And before coming into this administrative position, looking after the mental health program, she was a psychiatrist at the Central Prison Hospital in Bangalore. She worked there from 2004 to 2010. But in the last nearly 10 years after she has taken over, Karnataka is one of the first states to take the district mental health program to every district of the state. And Rajani is a dynamic leader. I have known her personally. Being from Karnataka, I have had occasions to attend some of the review programs of the district mental health program. And I think as Dr. Alok Mathur said, that going down to the taluk level, there are taluk mental health programs. They have made a lot of innovations, the tele-mentoring program, the tele-monitoring program, etc. So Rajani is going to talk to us about all the comprehensive mental health package in Karnataka. And it is my great pleasure to invite Dr. Rajani onto the podium and make the presentation. Please welcome Dr. Rajani.
Good afternoon, everybody. Thank you very much, sir. I thank each one of the organizers for having given the opportunity to talk about Karnataka DMHP program. So, yeah. So this mental health burden, I think I request one of the persons to tell me when I'm crossing 15 minutes limit. So, yeah, thank you. So these things are known to everybody, mental health burden in the country. So the recent National Mental Health Survey, which is the latest what we have. So we know that the burden is huge. And then the treatment gap also is known to everybody. So it is between 80 to 90% is what we have. So the objectives and goals what Karnataka is focusing on to provide accessible, affordable and comprehensive mental health care, to reduce the treatment gap, to build the capacity in the area of mental health, and then to integrate mental health services into the general health care. Technology to maximum extent possible in order to achieve the above objectives. Once again, what do you want? Now? It's not shared, is it? Okay. You give me this. It is not shared that side itself. Okay. You want the PPT? Okay. You want me to wait or? Okay. And to leverage the technology to the maximum extent. So I would be going with the DMHP status report and few innovations what we have done, and then the background work for DMHP work and few future directions what we have. This is about the status report. I'm sure all of us know that Karnataka is a pioneer in terms of, we are very happy to have Mohan Isaac sir here, because the district mental health program pilot started in Karnataka, that is Ballari model, which was taken up in 85 to 90. And post that, it was proved that mental health care can be integrated into the primary healthcare services. And then, though the National Mental Health Program was launched in 82, like many other states, Karnataka also was lagging behind till 2016. But fortunately, from 2016, we have expanded district mental health program to all the districts in Karnataka. And then coming to the clinical services, what we are doing through the DMHP services, we, for example, in 2015-16, before we took DMHP program, across the state, the footfalls in public health institutions were around 32,000. This is the data what I got. And gradually we have moved up in terms of number of consultations. I'm telling it is consultations, it is not persons, because we know that people come for follow-up regularly with us. We have given almost 10.63 lakh consultations last year. And in spite of COVID, this year also till January, we have given 7.81 lakh consultations across the public health institutions. This is not pertaining to, we have not taken the data from private institutions. And also the outreach camps have been going on regularly, and home visits. Also the counseling centers are there in each district has 4 counseling centers in colleges, workplaces, and urban slums. We have around 256 counseling centers where counselors go sit there in these workplaces and counsel. So we do a lot of information, education, communication activities across the state in all the districts in Karnataka. We make use of World Mental Health Day, International Day Against Drug Abuse, Suicide Prevention Day, and then World Schizophrenia Day, World Health Day. So all these days are celebrated across the state in all the districts in Karnataka at a time in a campaign mode. So we reach around more than 3 to 4 lakh people in these information, communication, education programs. This is one of the examples wherein a refurbished ambulance has been used in Chikbalapur district. It is a mobile van where a lot of IEC activities happen in various places in Chikbalapur, which has a very good reach to the people. And then many states, they don't ferry mentally ill in the 108, but in Karnataka we have sensitized 108 staff also to take care of the mentally ill persons. And 104, the counselors who sit in free health helpline, there also they receive mental health calls. They cater to up to around 70,000 mental health calls along with the general health calls in 104 every year. And we have also entered into an MOU with NIMHANS, and we have been doing a lot of collaborative work with NIMHANS. So this is Mano Chaitanya program, one of the flagship programs of Karnataka, where the DMHP team goes to the taluka level on selected Tuesdays, and all the 150 talukas in the state are covered through these programs. So people need not come to the district level for the mental health care. And this is one of the pictures what we have taken in Gauri Bidnor. The teams, they cater to around from 60 to 200 to 300 patients on each Tuesdays at taluka level. So for example, this is the Mano Chaitanya patient care data. Each year we cater to around 2 lakh people at taluka level itself. So this is Manasdhara program. This is the NGO, Karnataka government at the district level. We have collaborated with the NGOs where chronic mentally ill are rehabilitated through these Manasdhara centers. So this is one more Dawa Dua program where we have collaborated with many temples, priests of many temples, dargahs and churches. We have sensitized these people who are there so that they refer cases to our teams. This is one of the example of Murugamalla Dargah, where even in full moon day and Urus, when Jatra happens there, up to 10,000 to 1 lakh people come there. And many of the people have been left there because they believe that the chronic mentally ill will be cured because of the dua of God. So now initially there was a lot of reluctance from the faith healers, but we told like you are giving dua without dawa and we are giving dawa without dua. It's like buy one get one free for people. So please do continue your whatever rituals you are continuing and do refer people who need the care from psychiatrists. So our team from DMHP in Chikbalapur, they visit this Murugamalla Dargah every Wednesday, and they are catering to around 100 persons every Wednesday there. So many have been reintegrated to their families also. So this is telementoring program which actually started in Karnataka. Now I think it is it has been expanded to other states also in collaboration with NIMHANS. So this was piloted in Mandya district of Karnataka after showing to the government of India that sitting at the state hub center, we can actually telementor the primary healthcare doctor to cater to the mentally ill when they come to their public health institutions. So this was very successful. And just in Mandya at the PHC level, after telementoring for about 6 months, they had catered to around 15,000. Post this, we proposed to Government of India to take up this telementoring across the state. And fortunately, Government of India gave us 1 crore for this innovation, and we have expanded this across the state. And more than 500 doctors have been trained in this telementoring. So all of us know the advantages of telementoring and the care at primary healthcare level, because there will be less burden from the psychiatric disorders. We ensure that the treatment gap comes down, and then it is very easy for the patients to go to the nearest public health center to their house. So to add to this, now under Ayushman Bharat, we have health and wellness centers wherein the sub-centers have been converted into health and wellness centers. We have mid-level health providers. In Karnataka, we have recruited staff nurses who are the mid-level health providers. They go through 6 months of bridge course. So all the 12 packages starting from maternal and child health till mental health services should be provided at the sub-center level itself. So for 5,000 population, we have 1 sub-center. That means 1 primary healthcare center will have 5 to 6 sub-centers. So this is the nearest to the doors what we can cater to the people. So recently we have had around 6 days of orientation to around 2,000 MLHPs across the Karnataka to how they can do brief counseling, early identification of mentally ill, and then they can refer to the nearest PHC or Taluka Hospital, Mano Chaitanya Clinic, or to the district hospitals. So this linkage also has been started. So this is assisted home care or care at doorstep. So we piloted this in 3 districts in Karnataka, that is Ramnagar district, Bangalore urban, and BBMP. So this is basically to help the severe mentally ill who have been dropped out and missed out of our treatment ambit. So usually they make a line list of severe mental disorder patients, and then if they miss out or drop out, 1 call from social worker has brought back more than 40% of the people back into the treatment habit. Whoever doesn't come, our social worker or the nurse, community nurse, do visit the houses. So this has given us very good results. So now we have started expanded this across the state under innovations under a Kshema program in collaboration with NIMHANS. So this is actually in the disaster last year, wherein we had given mental health support to more than 12 districts in Karnataka for flood affected people. So along with the physical health, even the psychosocial support was given to all. So this is one of the examples of IEC. For suicide prevention, we do a lot of IEC activities. We do bus branding like this, train branding, and skywalkers in the bus stops where big platforms are there. We do a lot of IEC activities. These were few awards what Karnataka won. This is a BW Business Award for Telementoring Services of Karnataka. So we had won some 2 Scotch Awards for integrated mental health services into the general health care services. And then this is the national summit where Karnataka comprehensive mental health care was selected as one of the best practices. This is like using the DMHP funds. We had brought back a mentally ill person from other state who had wandered away from Mysore. So she was brought back in flight, this mentally ill person who had schizophrenia, and treated. So during COVID-19, we knew that a lot of people need mental health support. To be precise, before even the first case in Karnataka was positive, that is March 9th, we took a decision on March 7th itself that mental health care support should be given along with the physical health catering to the positive COVID-19 positives, isolate those who were in isolation, quarantine, migrants, and then the doctors and nurses also, along with media champions. So happy to share that till today, almost we have given 11 lakh telephonic consultations. This is teleconsultations. Our DMHP teams, they're doing wonderful work day and night. And along with the in-person consultations, we have given 11 lakhs teleconsultations. So this is about e-Manas, which is, I think probably Karnataka is the only state which has brought in e-Manas. This is a web-based platform. Karnataka statewide digital registry of mental health establishments. This will help us to register all the mental health professionals. And then we are moving into the inpatient and outpatient modules also through this. This is again through innovations under DMHP funds from Government of India. We have developed this from past 2 years in collaboration with NIMHANS and IIITB. So by this interactive portal, we will be able to implement Mental Health Care Act 2017 by letter and spirits. Now many states have been coming to Karnataka to study this. Recently, Maharashtra state had come here. They have studied e-Manas and we have supported them to put in innovation also. Telangana also is calling us. So we are happy to share this with other states who all want this. So this was launched by our Honorable Chief Minister recently in June 2020. So this is a few camps which happened for migrants and other people. This is the initiative what we took during COVID-19 for media champions. And then we also did anti-stigma campaigns during COVID-19 because a lot of people who were getting discharged after COVID-19, they were being abandoned from the houses. So this is the Kshema project which we have launched recently and it's going on very well. We have expanded district mental health program and we have come down to taluka level. We have taken 10 talukas where we have 1 psychiatrist and 1 social worker. So we have also launched one more program, health system response in handling violence against women and children, because mental health component is a major component while there is violence against women and children. We have started piloting this in 4 hospitals, that is Chikballapur District Hospital, KC General, Jayanagar General Hospital, and one more, Bowring Gosha. So this is a statewide sensitization of how we can cater to or help women and children who come with violence. So recently in the national summit, 7th national summit, e-Manas was selected as best practices. So this is one of the pictures where our additional chief secretary is presenting about e-Manas too. So other innovations what we have already taken is artificial intelligence and data analytics to enhance mental health care services in Karnataka. And then Kshema, as I told, and we have an e-monitoring system wherein every month we assess the physical and financial progress of all the districts. And with that, we have done around 87% expenditure last year. I think one of the, I think we are the largest expenditure states in DMHP. And then the telementoring, as I told, Mano Chaitanya and Davaduva programs. So next year innovations, we are starting assessment and interventions to reduce suicide intent and future attempts among suicide attempt survivors. And then Kishore Swavalamban program, and then expanding care at doorstep across the state. So this is one of the pictures how we have recently started this. This is the analysis how artificial intelligence is very helpful for us. This is like number of consultations district wise. Prior to this, we have huge data, but we don't know how to analyze and how to reflect this to the districts. So using artificial intelligence, we can actually, this is based on the population and per 1,000 people. This is like number of consultations taluka wise. This is number of consultations district wise per 1,000 people. So by seeing this, we can actually reflect to the districts, like, look, this is your performance. How can you strengthen this? And for example, if a taluka is doing well, this will help us to take a policy decisions, like we can propose to more psychiatrists, more social workers. So without this kind of a analysis, it would be very, very difficult to handle huge data. So I think Karnataka is the first state to take up artificial intelligence in mental health. Of course, artificial intelligence data analytics is used in various other fields. So way forward would be, like, we have already started mentoring mid-level health providers at sub-center level. We are planning to launch Matru Chaitanya, that is integrating mental health services with the RCH programs. And then we have also planned integrating mental health services with RBSK, RKSK programs, and also Kshaya Kshema, which is like, now the TB also, they are planning national TB eradication program. By 2025, the government of India has taken a decision. So we are starting Kshaya Kshema program also. So basically we are planning to integrate our mental health services with other programs because working in silos may not help. So thank you very much for patient hearing.
Thank you. Thank you very much, Dr. Rajani, for making a very quick and brief presentation of lots of activities that the Karnataka mental health program is involved in. What I mentioned earlier, I believe now is really true. Karnataka is showing the way for the rest of the country and the other states. EMNS program using artificial intelligence for data analysis, etc. I'm sure many of you will have lots of questions and comments. Please do put them down in the chat box, and so we'll have a look at that. And then if there are any which we need to request Dr. Rajani to answer, we'll come back to her later on. Now, from the south of the country, let's move to the west of the country. And very often when you look at various health parameters and performance, etc., along with the southern states, another state which very prominently comes up is Gujarat. So we are now moving to Gujarat, and the presenter from Gujarat is Dr. Ajay Chauhan. In fact, when you talk about mental health or psychiatry in Gujarat, the name which most prominently comes up is that of Dr. Ajay Chauhan. Why? Because he is the state program officer for mental health. He is a medical superintendent of the hospital for mental health in Ahmedabad. He is a member secretary of the state mental health authority, Gujarat. And Rajani did talk about the Dawa and Dua program, and she showed us that temple where thousands of people come. Every 15 days, the district mental health program goes there. But I think the Dawa Dua program, the other two states in the country which have been having very active Dawa Dua program is Gujarat and of course the Tamil Nadu, Erevadi. Tamil Nadu is not figured here because Karnataka represented the south, and now we'll move to Gujarat. And it's my great pleasure to invite Dr. Ajay Chauhan to come and make the presentation. Please welcome Dr. Ajay Chauhan.
Thank you, sir, and good afternoon to all. Just to give me a minute. So, respected Dr. Mohan Isaac, sir, because I learned mental health program, especially community psychiatry from you way back in 2000, because you are my mentor for the community psychiatry and even the district mental health program. So we learned lots from the Dr. Isaac and Dr. K. Sekhar for implementing a district mental health program in the state of Gujarat. So I give just a brief of Gujarat. In Gujarat, like we have all type of mental health facility, like we have 4 mental health hospitals, then the medical college psychiatry units in the government hospitals around 19. Then this, we do have all the districts, like all 33 districts have a district psychiatry units and a DMHP program. Also, we have a day treatment facility and even that we also have apart from 33 districts, we have like 4 major municipal corporation like Ahmedabad, Baroda, Surat, and Rajkot also have a DMHP program. So Gujarat is like first state they start urban mental health program in the state before 2 years. Also, we have taluka mental health program that is a state funded, and currently we have like 18 taluka. They have a 4 years taluka mental health program, and state support psychiatrists, psychologists, and medicine and other activity in the taluka with the grant in aid institutes. Uh, we all know that Karnataka is doing quite well for DMHP program, but in Gujarat we start that how we can reach out to the public at the grassroots level, and for that we plan our DMHP program in different ways. Like we more focus on preventive and promotive services for the mental health, and for that we initiated a school mental health program. So like initially, like Gujarat have school health checkups since last 12 years, and the last 4 years we include mental health checkups of the all the childrens from 0 years to 18 years in the all schools, all government schools, municipal corporation schools, and even the Anganwadi and other schools, and the private schools also. So around 48,000 schools they have a mental health checkups in across the state, and that is in the mission mode from like August to January. This 6 month, our chief minister launched this program, and they monitor each district. And we added last 2 years with the school mental health programs. We added the BISEC, that is a dedicated health channel, and through this health channel we train all the 42,000 teachers, the mentor teachers through the BISEC program. So identification of the child mental health problems, the problem childs, and the counseling skills to the children. And also we started the peer support volunteers programs in the schools. So the especially students of the 8th, 9th, and 11th, they train on the counseling skills, and they identify the mental health problems among their peers, and then they refer to the teachers, and teachers do some counseling, and then if required they refer to the DMHP team. So this is initiated last 3 years. Also we have child guidance clinics at the hospital, all the district hospitals and medical college hospitals, and there we have a special like a child psychologist and psychiatrist. They screen for the child health problems and other things, so that prevention work can be done. Also we have a community outreach camps in the taluka and the below the taluka up to the PHC and sub center level. So we have another innovative program, that is Atmiyata project. Atmiyata project is early identification and referral by the Farmers Club and Sakhi Mandal. That is a women's self-help groups. So we train the women's self-help groups and the farmers clubs with the innovative videos. That is like a probing video of 5 minutes to 7 minutes video, focusing on the mainly stress-related issues, interpersonal relationship, and the substance use, especially alcohol and other issues. These 5 videos, that is only like 30 minutes video that is shared with the Sakhi Mandals or the farmers clubs, and then the Atmiyata champion and Atmiyata Mitra, they explain them importance of the mental health and how they can identify the problems. So in the group of like 5 to 10 people, they share this video, and then they discuss about the problems in their village, and then they identify the person and then refer to the DMHP team. Also, we have another project that is called Spirit Project, that is Suicide Prevention and Implementation Research Initiative. That is, we mainly focus on the especially adolescents and youth suicides and the geriatric population. And we also implemented youth awareness on mental health modules of the WHO to the schools and the colleges. So that is like 5-day training program in the schools and colleges, and then youth are aware on the importance of the mental health, identification of the mental health problems, and then some lay counseling, and then how they can help to their peers and other things. So this program is also started with the Mehsana districts, now implemented in the 10 districts of the state. In the curative services, we have IP and OP services in all the district hospitals, sub-district hospitals, and the medical college hospitals. And beyond district hospital, we started a Friday clinic at the community health services. So out of 317 CHC, currently we have 190 CHC having a Friday clinics. So DMHP teams every Friday visit the CHC with the psychologist, social worker, and nurse. They see the patient at the CHC and dispense medicines and do follow-ups and other things, so that person cannot travel to the district headquarters and other thing. Also, we have follow-up care at the PHC. So we train the PHC medical officers and follow-up medicines as prescribed under the DMHP that is given to the PHC. All so out of 300 odd numbers of PHC, currently we have like 472 PHC. They do follow-up at the PHC level, and Gujarat state identified 35 psychotropic medicines and listed as a EDL drugs. So all the 35 drugs are supplied across the state, free medicines. Also, we have a de-addiction services in the 24 districts. So our DMHP teams do also have a special clinics of a de-addiction, and out of 33 districts, we have 31 districts have a counseling centers for person with the mental health problems. Also, we have a special clinics at the DMHP, that child guidance and mental retardation clinics, geriatric services, and that geriatric services is clubbed with the national program for elderly care. Also, we have a special epilepsy clinics, and also in partnership with the RKSK program, we have adolescents clinics and the screenings of adolescents at the taluk level, and even the health and wellness center. Currently, we started in the state. We have also a special activity, that is a camp activities for diagnosis of the mental illness, and also issuing the disability certificates. And we have like every Wednesday we have these camps. So in the camps, DMHP teams, also the officers from the social defense department and the other department, they attend the camps. They issue the they see the persons, diagnosed persons, given the medicine, and a person with the disability. They assess the disability percentage, and the UDID card is also issued at the taluka level, so that person can avail the disability certificates also at the taluk level. So all the disability benefits can avail by the person in the community. The Dawa Dua, what Dr. Rajneesh mentioned, that Gujarat is the first state that started a Dawa Dua program in 2006 after the Irrawaddy tragedy in the Miradatar Dargah in the Mehsana districts. Now we expanded this Dawa Dua program to across the state, and we train more than 317 faith healers on the identification of mental health problems, counseling skills, and the follow-up of the person. So and in the Dawa Dua program, especially in the Miradatar Dargah, we started a clinic in the Dargah itself only. Currently, we started weekly clinics, but now the demand is so huge. So daily OP services in the Dargah premises, that psychiatrists, psychologists, social workers, they run the clinics there. They do IEC activities and do awareness campaigning and other things within the Dargah. And even the National Human Rights Commission and the judges from the Supreme Courts, they visited this program, and they appreciate, and they said that this is an ideal community gatekeeper program for the mental health in the country. For the capacity buildings, we have prepared a special modules for the medical officers, ASHA worker, health worker, teachers, and even the village lay peoples. Also, we have special programs last 2 years that inclusion of mental health in the general health. And this theme of this program, we started training of all the medical officers, nursing staff, health worker, and community health officers, that is a mid-level health providers. So, but there is some problems of deputing the medical officers and the other officers for the training. So to overcome this issue, we started a digital training program. So we have a MOU with the NIMAS Digital Academy last 2 years, and we established mother hub at the NIMANS and the other hub at the Center of Excellence in Ahmedabad. And now we have a Gujarat Digital Academy for mental health. And through Digital Academy, we have a diploma program for community mental health. Also, we have a level 1 and level 2 program for the community health officers, and also for the clinical psychologist, social worker, even the other volunteers and other. And this Digital Academy is so busy to cater all the services through of capacity building in the state. Also, we have different modules for the like identification and referral of mental illness, especially for the counselor, village leaders, and teachers. And this we imparted training through BISEC program, that is a special setup by the Ministry of Science and Technology, and through this we train at a time around like 2,000 schools at a time for the training of the teachers and other things. Also special trainings of the DMHP staff on the de-addiction, women mental health services, child and elderly care in the mental health with the help of NIMANS and AIMS in the country. Also, we have a special program of support to the family through DMHP. We have a SATHI, that is a registered NGO. SATHI is like a Family Caregivers Association. Currently, they have working in the 10 districts, and they mainly provide the primary care to the families who need support, also understanding their skills and other thing, and how they ensure the medication compliance and follow up and do home care at the home care of the person with the mental illness. Also, they started a family psychoeducation program. Also, they developed the self-help groups at the taluka level and at the village level. Also, they distribute the pamphlets of awareness and other things, and they do also home visit to ensure the medication compliance and other things. And this is a backbone of our DMHP program, because involvement of family in the patient care is a key for the patient care in the mental health, especially severely mental health problems. Also, we have IC activity across the state. We have like poster distribution and wall painting in the each villages and other things. Also, we have a public awareness campaigning through the Gram Sabha, especially. That every village has a Gram Sabha, and DMHP team, they attend the Gram Sabha even in the evening hours and the late night. They discuss about the common mental health problems, even the substance use problems and other things, and they do group discussion. And this IC activity, like more referrals and identification, and this Gram Sabha activity is helpful in the reducing the stigma and acceptance of the mental health problems in the community. And this is very good activity at the community level. Also, through DMHP, we have 15 districts have the recreational and skill development units, occupational therapy units. Also, 4 places have a rehabilitation of long stay patients. Also, we have a special program of rehabilitation of wandering mental ill programs. We have a dedicated ambulance, and that number called Aadhaar Mental Health Helpline, and they do the rescue then admission, and after admission they cure and they rehabilitated with the family. And within 5 years, more than 15,000 people they reintegrated with their family. And this reintegration program is also appreciated by the National Human Rights Commission of the country. Also, we have a special program of psychosocial rehabilitation of disaster victims and rehabilitation of the street children with the different NGO in the 4 metro city of the state. Also, we have a community mental health, community rehabilitation of the severely mental ill program with the different NGO in the 18 districts of the state. Also, we have online disability certificates, and lots of NGO are involved in these services. Also, during this pandemic, we started 1100 toll-free helpline in the like 29th March of the 2020 that is launched by our chief ministers. And we have 24 psychiatrists and psychologists. They do round-the-clock services through 1100 helplines. Also, we have started e-Sanjeevani OPD during the pandemic, and the mental health services also included in the e-Sanjeevani OPD. And we have a daily around 30 to 40 consultation through e-Sanjeevani OPD in each districts. So gradually we expanded our mental health services through the technology based and also, and this year's we also plan that we have another program called empowerment, that like technology based training modules through TECO platform. That is a Gujarat government have a special technology and all ASA worker given the TECO mobile. So the mental health training modules launch that is like in the TECO mobiles, they do a self-learning and then mentoring by the DMHP team. They identify especially postpartum depression, and anxiety in the community. So first year we more focus on the depression and anxiety, and coming years all other disorders can be included in the TECO Plus application, so that all the ASA and the CHO, they do identification, referrals and follow-up services of the person with mental health in the state. Thank you, sir.
Thank you. Thank you very much, Dr. Chavan. In a short time, you have told us about various activities that the Gujarat state is involved in. I thought, before listening to you that it was only in Karnataka, lots of activities are going on, but I think you can really compete with the state of Karnataka. You're using technology to its advantage. Lots of programs, active liaison with the non-governmental organizations, etc. Thank you very much. Now, sitting here, as I look at the screen, I note that there are a couple of hundred people, listening to this program, watching this program. And although we don't have the facility of directly asking questions and answering questions, etc., I do notice that this is very interactive, because as I listen to you every now and then in the chat box, people have been saying something or the other. Sitting here, I can't read all that. Somebody is going through that and they will summarize. So thank you very much, Dr. Ajay Chavan. Keep it up. Continue doing this excellent work that you have been involved in. And now we'll move on from the west to more or less central India or the north of India, and that is the state of Chhattisgarh. It's my great pleasure to invite Dr. Sumi Jain. For a change, she is not a psychiatrist, but she is a public health professional. She has been a public health professional working in the public health department of the Chhattisgarh government state health mission. We have been talking about integrating mental health with primary health care. We have been talking about integrating mental health with the whole spectrum of non-communicable diseases. Dr. Sumi Jain is in fact assisting the National Health Mission as a state coordinator for all the non-communicable diseases, as well as mental health. In this capacity, she has been providing technical support for various health programs, which include the National Program for Prevention and Control of Diabetes, Cancer, cardiovascular disorders, stroke, National Program of Healthcare for the Elderly, and also the National Mental Health Program. We know from WHO documents, etc., that mental health has to be, very well integrated with the whole spectrum of non-communicable diseases. So now it's over to Dr. Sumit Jain to let us know about what's happening in Chhattisgarh. Dr. Jain, please.
Good afternoon, respected sir, Isaac sir. I think Alok Mathur sir also would have joined. Good afternoon, Alok Mathur sir. Good afternoon to Shekhar sir and all respected dignitaries, whatever and even other state nodal officers who have joined. And I think it's been enlightening to listen to them and learn from them every time. As a person who's working in public health, I work as a state program coordinator in Chhattisgarh, and I've been working for mental health program since past 4 years. So I'd be sharing the activities which we have done under district mental health program. So I'll just start my presentation. I hope the slides are visible by my end.
Yes,
Hello.
they are visible. Yes, they are good. They are visible. Please go on.
Yes, sir. Thanks. As you know that the mental health survey, which was done in Chhattisgarh also, so we have a small concise report of the mental health survey done by NIMHANS. So we can see that the treatment gap has been huge. The prevalence of common mental disorders have been 11.2%. Severe mental disorders are 0.8%, but the treatment gap is wide. You can see that in common mental disorders, the treatment gap is close to 80%. Severe mental disorders, it is 54.5%. Alcohol disorders, it's 78%. So we could realize seeing the report that, Chhattisgarh has to work very hard. And I think we have to put in a lot of effort so that we can improve on the mental health services in Chhattisgarh. If you just see the scenario in Chhattisgarh, that there are 28 district hospitals with us, 20 civil hospitals, and there are quite a few community health centers. 172 community health centers are there with us. There's just one mental hospital with us. So you can just see a scenario that the whole state has only one state mental hospital. It's a 200 bedded hospital with us. So this made a realization further that the DMHP has to work further, because we had very lesser facilities, which you can just see. The psychiatric units of medical colleges also, if you see, there are approx 7 medical colleges, including AIMS, which had facilities for mental care facilities. But the posted psychiatrist, if you can see, are very less in Chhattisgarh. And if you see the whole psychiatrist, the quantum of psychiatrists in Chhattisgarh are just 52, and maximum are doing private care service, and very few are there in the medical colleges, and rarely serving in the DMHP. So we always had the issue that we didn't have psychiatrists in all the DMHPs. So what we did is we felt that there's a need that we need to improve, and we tied up with NIMHANS for technical support and capacity building. Same way we tied up with Center of Mental Health Policy and Law for strengthening and capacity building related to Mental Health Act 2017. And we did another MOU with AIMS Delhi, NDDTC, for addiction disorders and capacity building related to addiction disorders in Chhattisgarh. If you can see the status related to the DMHP, there are 28 sanctioned districts in Chhattisgarh, wherein we are performing operational in 27 districts. The new district which has been recently formed, we have not been able to provide these services. After the financial support from ministry, I think this year we'd be operationalizing our new district, which is Gorella, Pendra, and Marwahi. Rest of the districts have been functional, and we have 26 teleclinic support also, which are running with the support of NIMHANS. So as I gave you a preview that there are just 52 psychiatrists in Chhattisgarh, and very rarely we have psychiatrists in Chhattisgarh. So this was a hard pressing issue with us that we don't have psychiatrists and how will we perform. So as per the tie-up with NIMHANS, what we did is we requested the recent eco model which is running. So we requested the psychiatry department to support us on training medical officers and the DMHP counselors on mental health, so that we can upgrade the skills of medical officers and we can make them run the mental health clinics in Chhattisgarh. So approximately we have trained 34 medical officers at the district hospital, and approximately 69 counselors. Previously 58 were trained and later we increased them to 69 counselors who have been continuously trained, and hand-holding is done by NIMHANS so that they are now able to run the mental health clinic at the district hospital. So you can see the widespread, availability of these trained HR who can run the mental health services in the district hospital. So you can see the trend also. We started in 2015. If you can just see our data, it was just 3,711 patients we could cater at district hospital. After that, due to the launch of this project, the VK in Eco project and the teleconsultation support by NIMHANS, and we have been continuing this project for past 3 years, and this year also we are trying to continue the project. And you can see a boom in the OPD in Chhattisgarh. You can see that in 2019-20, from 2015-16, we were just catering 3,711 patients, and now we have been able to cater last year 84,255 patients, and till January this year we have been able to provide services to 65,510. You know that COVID has impacted the OPDs a little, so the data is a little less than the previous year, but still we have to reach March to really know where we are with this year's our OPD services. So I think the support of this virtual eco network was really nice for our district hospitals. We can improve the services and we could cater to many people in need related to mental health at district hospital. You can see that there was a study also related to the same project that 80% of the people who had taken up the study, the capacity building initiative was fruitful, and they had confidence and relevance related to the subject, and more than 60,000 patients were catered by our DMHP, and there was tele-eco support with support of NIMHANS, so we could do much better. We had received an award also for the same project, Best Poster Award in India Science Congress last year, I think, on the same project. Next, we again realized that the same pressing issue was with us, that the treatment gap was 60%, and we were just catering the district hospital. So we felt that we have to expand our services in CHC and PHC. So we again approached NIMHANS, and we developed again a project called as CHAMP project, Chhattisgarh Community Mental Health Telementoring Project. This is for only primary care physicians who are posted at CHC and PHC. And this project has been, we have started it from July 2019, and we have been catering across the state. We have almost trained 22 district medical officers and assistant medical officers. This is like skill building. We are trying to build the skill of existing HR on mental health services, and we are trying to instill the skills related to common mental disorders, so that they can diagnose common mental disorders in CHC and PHC. You can see the data. You can see that there's been a downfall in COVID time with the data, and we have been able to cater 25,873 patients under this project. And most of the patients have received care at their CHC and PHC, and they don't have to go ahead to medical college or the nearby district hospital. So this project has been fruitful, and we are trying that we can improve more on this project, and we can get more doctors trained, so that our services run across the state, and the multi-skilling concept of medical officer is really taken up seriously under mental health also. This is one of the project, again, we are doing it with NIMHANS. I should always say that without support of NIMHANS, we wouldn't have done much. So this is a project we are doing with support of Boot Tutor. This is an artificial intelligence tutor. It helps in it's an e-learning platform for nurses, because we felt that our nurses have been, quite busy and they can't give a lot of time for, a lot of training related to mental health. So we felt that we can have an e-learning platform for these nurses. And initially we are training almost all the nurses in the state on de-addiction and basic mental health. And we have started the project at district Dhamtari, and now phase 2, we have taken up 3 to 4 districts. Baloda Bazar, Bastar, Kankir, Rashnandgaon, and we are trying to cater almost all the nurses, because what we felt is nurses are in real contact with patients. Either it's an ANC patient, or it's any other patient in the IPD, and mental health issues are skipped. So we felt that nurses are also to be trained on mental health. So we have taken up this project, and we have just initially started with this project. Hope this project fetches more result to us, and there are more referrals to our district hospital and the CHCs. This is the third activity which we are doing. This is called as the telementoring for rural health organizers, because we felt that the referral has to be having a chain link, wherein if the RHOs, that is the ANM and the MPW at the grassroots level, if they aren't trained, they won't be able to refer the patient to the right facility and the right trained doctor. So we have started this project to cater for identification and referral of mental health disorders among the RHOs. RHOs are the ANMs and the MPW who are posted in health and wellness centers. And after the basic course, we are planning that, because they are in contact. You obviously know that ANMs are midwives, and ANMs have to, work with children, adolescents, and geriatric population. So we are trying to specialize them on these aspects also. We'd be training them on children mental health issues, geriatric mental health issues, and perinatal. We have just started with the project. More than 12,000 RHOs will be catered under this project, and we have taken up this project for 3 years. And again, this is by support of NIMAN. So I think we'd be able to perform better. There'll be more referrals and there'll be more support. This is, I think, one of the very important training, because the most important person in a village is the ASHA worker. ASHA workers go to house to identify people who are having any health issue. So if mental health is not catered to ASHA workers, I think the real referrals and real identification of patients won't occur. So we also have taken up the same activity of ASHA workers. ASHA workers are called as Mitanin in Chhattisgarh. So we have taken up training of Mitanin in 2019-20 and same way 2021, so that almost all Mitanins are trained on mental health issues. Last year we could train 60,000 Mitanins on mental health issues, and we are trying to take up round 2 training for Mitanins this year also. So we have taken a few topics for Mitanin which are quite relevant to the community mental health issues. So we have taken suicides also as part of this manual, addiction as part of this manual, chronic mental disorder also as part of this manual. You can see just have put the manual, just a detail of it. So I've just put few pics related to the Mitanin training, how Mitanin training occurs in Chhattisgarh. We did a workshop with support of many dignitaries. Rajni ma'am, Ajay sir also was with us. We could try to develop a state strategy for mental health, and mainly we worked on life course, because we felt that if we have a strategy in this area, we can work better. So we worked on areas of addiction mental health, vulnerable population, perinatal mental health, child, adolescent mental health, health and wellness center, so that we can develop our own strategy so that we can work much better. This is the workshop we had. This is one of the activity which we are doing from the PSW department of NIMHANS. Dr. Arvind Raj sir always supports us for this training. We try to train these school and college teachers as counselors in school. We provide them support like telephone and basic IEC materials related to mental health, and they have general talks on mental health at schools and colleges with support of DMHP. And we provide support for special counseling day with clinical psychologists. And we have catered more than 270 schools and college teachers have been trained. 67 schools and colleges have already started the counseling units, and more than 6,000 patients have been benefited under this project. Under suicide prevention in Chhattisgarh, you can see the status. Chhattisgarh has been, second highest in suicides in India after Sikkim. So we are doing very badly in suicide. So we felt that we have to work more on the areas of suicides also. So we have done few work related to suicides. So I'll just put a glimpse on that. We worked on the state consultation on state suicide prevention strategy. We had experts from Pan India. We had Dr. Alok Mathur sir with us and WHO Dr. Atrey Ganguly. Again, Ajay Chauhan sir was with us. Madam from Karnataka, ma'am also was there with us. And many dignitaries were there who could really enlighten us that what we have to do really on suicide prevention. And we could come up with a strategy for ourselves so that we can build on in this area. So what we did is we found one important thing that there should be a media watch and media has to report rightly. So we worked, we partnered with Sneha and there's one NGO called a CFAR on right reporting, and we did a capacity building of our own nodal officers on right reporting on suicides. And we did series of workshop across state on right reporting related to suicides. So you can see that there have been series of sensitization workshops. We have met 1-to-1 to 16 editors. We have met 250 media personnel on right reporting, and we have done series of workshop with support of district collectors, police, IPS officers, everybody, so that the media gets sensitized on right reporting practices. We worked on, improving the number of gatekeepers in Chhattisgarh. So what we did is we took all our 27 DMHP, now they are 28 actually. And we had Dr. Krishna Prasad sir with us and Padmavati madam with us. So they came and trained our, DMHP staff on gatekeepers. We could do so many activities. You can see life skills, suicide prevention, workplace stress management, outreach camps. We could benefit many people, across state. We sensitized 104 helpline people also that they, can act as a distress helpline. So we trained them with support of Jeevan suicide helpline. And train them thrice so that they can really work on areas, and wherever there are calls related to distress, they can also take up such calls and help such people. There was a new initiative in Chhattisgarh. This was done by support of Collector Mahasamund and the DMHP team Mahasamund. This was special initiative on suicide prevention called as the Navjeevan program. Navjeevan program had, gatekeepers called as Sakha and Sakhi, which were working at community level. These grassroots Sakha and Sakhi were trained on gatekeepers. There were, prereks from school. Actually, school teachers were sensitized on identifying such children who have, mental health issues and, they are at suicidal risk. They were identified. And there were committees which were formed at district level by the, collector was heading the suicide prevention group at district level. And there was a monitoring committee at the block level also. And every death was audited in Mahasamund. Every death, suicidal death was audited to find out what was the reason why the person died and how can we reduce suicides. And approx close to 6,000 people were benefited in this Kendra. You can see the photo, Navjeevan Kendra. Navjeevan Kendra is just a, a hall, a community hall, wherein, philosophical books, good books were kept. And, it was a place where people can come and relax and they can entertain themselves with few games, outdoor games, indoor games, and they can read books. And there are approx 200 Navjeevan Kendra in Mahasamund. And these Kendra are, having Sakha and Sakhi. And these Sakha and Sakhi identify such people who are in distress and they counsel them. So this was a very nice initiative which we are planning this year to, launch Pan State in Chhattisgarh. The few initiatives which we keep doing on suicide prevention, few signature campaigns, I love myself, and few activities like selfie zones for instilling self-importance with people. So these are the activities we do it every time. And one of the activity which we have started in Chhattisgarh is from April, we identify attempted suicide cases who get admitted in our own hospital. District hospital and CHCs, there are many attempted suicide cases who come and get admitted. So studies say that if you have constant contact with such people, further attempts can be reduced. So we cater the same thing. We identify such people and we counsel them. Our DMHP team have been trained on suicide prevention gatekeepers and related to counseling of such people on distress. So approximately this year, if you can see till Jan, we could identify 5,488 attempted suicide cases, wherein 4,685 attempted cases have been counseled by our own DMHP team. And this is just not one single contact counseling. Every month they call them and they speak to them for their well-being and counsel them for their issues. COVID and mental health also isn't, everybody knows that mental health has been important, and we also could work on this area. Till date, we could identify in the 12,168 patients who have been counseled by the who were admitted in the COVID care center, and those in home isolation were also identified. 20,515 were counseled on mental health issues. Our MD NHM was very, insisting on that if there is chronic psychiatric disorder and if they are COVID positive, then they would need special care. So we got a 10-bedded special facility on COVID-19 patients who had psychiatric issues. And we could support 52 such patients who had chronic mental disorder and COVID positive they were. This is just a small note which our MD had always put through. No one else can play your part. So on suicide prevention, Zindagi Chune Vijeta Bane was one of the campaign which already we did in 2019, and every year we do the same campaign. So I end my talk by this. Thank you.
Thank you very much, Dr. Jain, for the excellent presentation. A lot of people in the audience would not have really known what is happening in Chhattisgarh. You have given us a broad overview of whatever is happening, and we are indeed delighted and impressed with all the work that has been going on. Now, my co-chair is not sitting with me, Dr. Shekhar, he is sitting somewhere else. I will, of course, ask him to give some comments later on, but I realize that I have been an utter failure as a chairperson. Why? Because the sessions were to start at 3 o'clock and were to end by 4:30. The organizers told me that, of course, there'll be little, while transferring from speaker to speaker, etc., there'll be little waste of time. You can exceed the time a little bit. But the instruction they gave me was that each speaker can be given 10 minutes. But all the three speakers so far were speaking about all new programs about which most of us, at least I didn't know very much about. I had no heart to stop them at the end of 10 minutes or 12 minutes or even 15 minutes. So I would request all the participants to stay on to listen to the last speaker, and that is from the state of Manipur. I know that the numbers, I'm sitting at the screen, I can see at the bottom the numbers. We have been steadily holding the audience. The numbers have not been drastically coming down. The only disadvantage is I see already more than about 75 or 80 chats. I don't think we'll have time to discuss all that. But I would personally request the organizers to put them up, collate them and then send it to all the people. And before, we are going to listen to the last speaker, but already I don't want to forget to make this comment. These are all excellent work that you are doing, and not many people in the field of mental health know about this. As Dr. Sumi said, that there are so many psychiatrists, not very many, but the numbers of psychiatrists in Chhattisgarh, she said that most of them work in the private sector. The ones who don't work in the private sector, they are in the medical colleges. And not many are interested in the district mental health program. I think all the three speakers, I'm referring to Rajani, Ajay, and Dr. Sumi Jain, and now we are going to have the speaker from Manipur. You should put together these 4 states' presentations in a kind of a publication so that people will know. This is all excellent work. I didn't know that Chhattisgarh had taken over many other states to become number 2 as far as the suicides are concerned, but you are doing excellent work. So keep it up. Thank you very much, Dr. Sumi Jain. Now we move on to Manipur. This is the northeastern state. It's almost the bordering state between Myanmar and India. To speak to us about what's happening in Manipur is Dr. Atokpam Ranita Devi. She's a psychiatrist. She is not a public health expert, but she's a psychiatrist, and she works as a district psychiatrist in one of the district, Tobol district in Manipur. She completed her MD, not from NIMANS, not from PGI, not from AIMS, but from the Regional Institute of Medical Sciences in Imphal, an excellent institute in that region of the country. She is also working as a state nodal officer for National Mental Health Program and the District Mental Health Program based in Manipur. And she also has the additional charge of the COVID-19 related psychological problem. May I now request Dr. Ranita Devi to make the presentation? Doctor, please welcome Dr. Ranita Devi.
Thank you, sir. Sir, am I audible, sir?
Yes, very much. Please go ahead.
Thank you, sir. Thank you for giving me this opportunity. Before I start with my presentation, I would like to express my heartfelt thankfulness to Madam Rajani, because in the beginning, she has come down to Imphal and she has taught me many things. So like, she is my mentor type, sir. I just wanted to take this opportunity and express my gratitude to her in this forum, sir. Now, may I quickly start my presentation? Like all of us have heard such wonderful implementation of DMHP in various parts of India, and Manipur as such is a very small state. As we all know, it's located in the northeast part of the India. And I'm not presenting because I'm doing very well or something, but I'm just sharing my experience. In Manipur, we are just in the initial stage of DMHP. So I'm very lucky to have been given this opportunity to share some of my experience and work in this forum. Thank you all once again. As we all know that GOI had launched NMHP in 1982, and to meet the objective of NMHP, DMHP was launched in the year 1996. In Manipur, the journey of DMHP is not very smooth. Frankly speaking, like it was first launched in Imphal East district in the year 2000 as a pilot program. Then again in 2004, it was expanded to another 2 districts. Then later on, again in the year 2007, it was expanded to other districts when it was a vertical program. And the program continued till around 2011. After that, the program almost went to a halt. Then the staffs were continuing their activities. They were assisting in the health services activities and all after 2011, but the program funding and all were not regular because of certain issues. So the program was not in a very good shape at that period of time. But later on in 2018, again, the program was like after subsuming National Mental Health Program in NHM in the year 2016 in Manipur, in the year 2018, program started slowly reviving again. Then it was expanded to 4 districts. And later on in the last year, that is in the current year, during 2020-21, during the second, since the second quarter of this 2020-21, the program was expanded to all the 16 districts. And we also, I would like to highlight that Manipur has also some newly created districts, and it's really like we are really struggling with the program because 90% of our state is also hilly area, and we have many difficulties facing in relation to program implementation as such. Now coming to the HR status, we have identified 16 district nodal officers who are very dynamic, out of which only 6 of them are psychiatrists. They are posted in Imphal East, West, Hobal, Chandel, Bisnupur, and Churasanpur. Remaining 10 district nodal officers are trained medical officers. They are very dynamic and they are very enthusiastic. Because of them only we are running the MSP successfully. We also have a problem in HR right now, even though all the HR posts have been approved under ROP, but implementation process or the recruitment process is a little bit slow in our state because of certain reasons. So by the maybe within a year or so, when the recruitment process is being completed, fully completed, we can see a more brighter side of DMHP implementation in our state. In our state, we are focusing the DMHP program mainly on these 5 components, that is clinical services provision, training of healthcare providers, provision of essential psychotropic drugs, ICBCC activities, and targeted intervention programs such as school mental health, college counseling, workplace stress management, and suicide prevention. More so like when we compare with the previous learned speakers, the MISP implementation in Manipur right now is in a very primitive stage, I would like to say. Regarding provision of psychotropic drugs, our state EDL has included 13 psychotropic drugs which are made freely available to all the district hospitals, CICs, PICs, and health and wellness centers. And under NMHP, we have also made a provision for procuring additional number of psychotropic drugs, as we all know that treatment of mental health disorders require a wide range of medications apart from the list included in the state EDL. Now coming to the training part, we have actively engaged in training program since 2018. We have trained various medical officers, around 349 medical officers were trained in collaboration with Department of Psychiatry, RIMS. And it's a 4-day training program with 1-day practical exposure at Department of Psychiatry. During the practical 1 day, the trainees are being exposed to history taking, then case discussion, all those like they are being taught how to like come to a diagnosis, how to like write prescription, all those things were taught on the 1-day practical exposure. Similarly, training for nurses are also being conducted for a period of 3 days to empower them so that mental health services can be integrated into general healthcare services. Apart from the training of these medical officers, nurses, and paramedical staffs, we have also conducted various special training programs like stress management training program, life skills training program in collaboration with learned faculties from NIMHANS Bengaluru. Stress management TOT training were conducted in November 2019. Life skills training was conducted in February 2019. And after the training program, we have conducted like various stress management, workplace stress management program. For example, we have approached various army camps, then Jawans. We have taught them many stress management activities. We make them understand what is stress, what will be the impact in their life. We make them learn skills, etc. by doing various group activities, role plays, games, and also making them learn certain practical skills suitable to their place of posting or suitable to their job. And also recently, as we know that because of the recent COVID-19 pandemic, many of our frontline workers are under immense stress and pressure. And because of that, Ministry of Health, WHO India, and Department of Nursing and Clinical Psychology, Department of Clinical Psychology, NIMHANS, have jointly formulated TOT training module for promotion of mental health for healthcare workers. And some of our nurses have taken had joined their TOT training program, and following which we have started training of our nurses in the state. We have finished 2 batches of TOT training in this month. We have completed on 8, 9, 11, and 12 February. And further, we have submitted a proposal. And once this proposal is accepted, we are now going to train 121 TOTs in this coming month. That is by March 2021, we are planning to complete training of 121 TOTs so that these TOTs can further train their district level nurses regarding this training program. We know that ICBCC activities is very much important for mental health program because stigma is very much attached with this mental health condition. So we have been conducting various ICBCC activities both at state and the district level. For example, we observe these important mental health days both at state and district level, like World Mental Health Day, World Suicide Prevention Day, then International Day for illicit drug abuse and trafficking, World Alzheimer's Day, Then during this observation days, we also take the opportunity to conduct various state level symposium competition for the students, essay writing competitions, etc., so that the young brains are being inspired to know about mental health disorders and how to prevent these disorders and how to develop healthy mental health for the welfare of their future, etc. Also, as part of the ICBCC activities, we frequently organize media briefing, media interaction program, live TV talk, radio jingles, for placement of hoardings, then newspaper advertisement, micings, etc. And also as part of the targeted intervention program, in the targeted intervention program, we are mostly focusing in preventive and promotive activities, and all our DMHP teams are very much active. They usually go to school, colleges, workplace, destitute home, even urban slums, etc. And they teach them certain life skills. They teach them certain mental health promotive activities so that their mental health is being taken care of and they have a bright future. Also, as part of the outreach activity, we also conduct various health camps, especially these health camps are usually conducted in remote areas, hilly areas, and in those districts where psychiatrists are not usually available. Our DMHP teams are also actively coordinating, and they are also going for outreach clinics to jails twice a month, and also to selected PICs, CICs, and health and wellness centers in giving their service to the needy. Also, for the severely ill and irregular patients, our DMHP team and NMHP teams are coordinating, and they're visiting the patients at home, at their doorstep, and giving service. As we all know that mental health is one of the 12 service provision under Health and Wellness Center. Officially, mental health care facility was made operationalized in selected 37 Health and Wellness Center on October 2019. Before this, we had trained more than 300 CSOs, ANMs, MPWs under National Mental Health Program Manipur. Simple reporting format was designed and given to them. And during the COVID-19 period also, this much number of awareness programs were conducted. Around 50 psychoeducation were given at these health and wellness centers, wellness activities like yoga, deep breathing exercises, and some light aerobic exercises were also taught as part of the wellness activities in health and wellness centers. And sometimes screening of mental health disorders are being conducted, especially now we are focusing for the elderly population by using MMSE tool, then by using geriatric depression scale, geriatric anxiety scale, etc. And also these health and wellness mid-level service providers, they are referring cases to the DNO when they find such cases, and also sometimes they attend e-Sanjeevani OPD along with the patient and getting treatment at the community level for those patients who are in need. So these are some few of the pictures, few awareness program of mental health which are being conducted at health and wellness centers. Even World Mental Health Day was celebrated very lavishly in one of the health and wellness centers. Children were participating in entertainment program. They were having some dance and music program during the World Mental Health Day, so that people could be like given widespread awareness by organizing such attractive, interactive, and cultural program. So coming to the ongoing clinical services, DMHP, we have both OPD and IPD services for mental health at various districts. In our state during this COVID-19 pandemic, almost all the OPDs were closed down except for some casualty and emergency services. So the clinical services came down drastically during 2020-21. But before that, we were having regular OPD, IPD, psychotherapy, counseling service, home visits, drug treatment program like detoxification, long-term management, relapse prevention, etc. were going on independently in our DMHP OPDs as well as in coordination with other program like drug treatment center program of NACO, MAX, etc. We also have provision of assessment of IQ and other psychometric tests in our DMHP centers where psychologists are available. And also disability certification for mentally disabled patients are being carried out in our DMHP centers. So our state is having a population of around 3 million, and majority of the cases are going to the 2 tertiary care hospitals, RIMS and JENIMS. But slowly we can see a increased patient treatment seeking behavior at the community level at our DMHP centers. In the last 3 years, total cases are gradually increasing, even though the cases have been seen decrease in this year because of the COVID-19. So like our DMHP team also took active role in psychosocial support during this COVID-19 pandemic. And we had formed DMHP along with some other stakeholders like our DMHP team along with some volunteers and counselors from other program divisions like RKSK, ICT counselors. We made a group and we formed 15 psychological support team and 1 state psychological support team, which was initiated during the month of March 2020. And we had operated 24/7 psychological support helpline. Initially, it was through the 3 mobile numbers, but now we have launched a dedicated mental health helpline 104. 104 currently in the state of Manipur only for the mental health. And as part of the psychosocial support, various field visits and home visits were done. And also like on-spot visit to the quarantine and isolation centers were done. Then various teleconsultation services were provided through this psychological support team. And we have also trained more than 1,000, around 2,000 doctors, nurses, frontline workers. And we have oriented them about stress management and psychological support during COVID-19. And apart from the IC activities of DMHP, separate IC activities for the COVID-19 were conducted. We had made various short videos on stigma prevention, suicide prevention, social media campaigns were done, TV talks, radio jingles related to psychological supports were done. These are some of the pictures which are showing the activities of psychosocial support. We have done migrant workers counseling, juvenile home visit, then quarantine center counseling, video, then training. These are some of the pictures of the psychological support which have been rendered by our DMHP team. So summarizing some of the achievements of DMHP in Manipur, even though we are in a very primitive stage, I should say, as compared with the other big states, we have completed training of 349 MOs and 482 nurses and paramedicals. Life skills, we have trained more than 142. Then stress management, TOT, we have trained around more than 500 people. ICBCC activities, targeted intervention programs, health camps, field visits, and home visits are ongoing activities. We have completed more than 1,000 outreach clinics. There is an increasing trend of patient enrollment in the DMHP services. We have also initiated mental health activities in health and wellness centers. Our DMHP team had played a key role in psychological support during COVID-19, and Manipur has initiated dedicated mental health helpline 104. Some of the issues are, there is a huge stigma attached to mental health conditions in our state. We need to do a lot of IC activities for this. There is a slow HR recruitment process, and I am like, we don't have a mental hospital till now in our state, which is very we have been trying to have this one, but unluckily still now we don't have a mental hospital. And there are certain issues regarding fund, and because of the difficult geographical terrain, sometimes we find it very difficult to implement DMHP. Way forward is, we are planning to strengthen mental health services in new DMHP centers and all the health and wellness centers. We want to initiate and strengthen school mental health program in the coming days. And also our state does not have this one government daycare center. We have only 3 or 4 NGO-based daycare centers. So, but still then we are trying very hard. We are trying very hard, and ministry has also approved to start one pilot project of this daycare center in PPP mode. And hopefully we are starting this PPP-based daycare center in the coming year. And we are also looking forward to decrease overall morbidity through DMHP. Thank you.
Thank you. Thank you, Dr. Radhika Devi. All those who are still with us would agree with me that we have had 4 excellent presentations from 4 very widely different states. One in the south, one in the west, one in the north, and one in the northeast. Now, we were supposed to finish this program by about 4:30, maximum by 4:40, but actually it's going to be 5. Strangely, surprisingly, and very pleasantly, I find the numbers are only going up. It's not going down. And as I see the screen here, the Zoom screen, it's more than 313 now, which means that all the presentations were very interesting. We have had nearly 100 chats. There's no time. If I take up all that and ask all the participants, the speakers to respond, then we'll see the numbers dwindling. I don't want that to occur. What I would do is I'll just to give you a flavor of the kind of concerns which people have had, the kind of questions which have come up. I'll mention some of them. Many of them are of an administrative nature. Why is the pay in the DMHP different between clinical psychologist and psychiatric social worker? What is the minimum qualification for a psychiatric social worker according to the Mental Health Act in the DMHP? Why is that in Tamil Nadu, for example, the social workers who are working in the DMHP all have different qualifications? Whom can I write for a clarification? There are also other more relevant questions. Why is that in the state of Chhattisgarh, in none of the medical colleges, there is any postgraduate training program in psychiatry? I think somebody picked up that from perhaps Dr. Sumi Jain's slide. Anyway, these are all questions. I'm not opening up for active discussion because I don't think that it will be possible through this kind of a platform. But there are also some serious questions which I would like to raise. What is the impact of Mental Health Care Act 2017, especially on the role of the psychiatric social worker in the DMHP? Has DMHP been implemented in all the districts of Himachal Pradesh? Maybe Dr. Alok Mathur is a person who might be able to answer that because we don't have a representative of Himachal Pradesh here. How are we going to address the serious mismatch between the DMHP ambitions and the availability of mental health manpower shortage for service delivery? But I think from all the chats, one of the things which is most important and which I empathize with as a chairperson is this comment, which I will read out. I think all the 4 presentations were about the excellent things that each state has been doing. So this person asks, instead of patting ourselves on the success of DMHP of India, can we plan to allow a third party, a peer reviewer, for a critical appraisal of the DMHP with special reference to manpower matching, recovery, relapses, dropout rates, and psychosocial interventions? I think this is the next phase that we have to do. I mean, since we have the senior person from the Directorate General of Health Services, this is something which should be kept in mind. As somebody who has been associated with the DMHP in its initial days, I know periodic review by the ministry, by NIMANS, and also an independent reviewer, the Indian Council of Marketing Research. The government of India paid a lot of money for an external agency to do a review. But during every review, although there were various kinds of pitfalls, it was advised that this is a program which should be continued. That is how from 1 district in Bellary to 4 districts in Andhra, Assam, Tamil Nadu and Rajasthan to 100 districts. Today, we heard Alok Mathur say that it is there in all the districts in the country. But the point which I think it is Dr. Sai Kumar who has mentioned is well worth taking. And now we need to go not just at the number of consultations. Of course, in Chhattisgarh, we saw the impressive increase in number of consultations from 3,000 in 2015 to 85,000 in 2020. In 5 years, of course, credit goes to all the trainers from NIMANS, various other places, the NIMANS Department of Psychiatric Social Worker trainers, etc., etc. So this is all impressive. But now what we need to do is, okay, are people getting better? What are the recovery rates? Are they relapse? Do people drop out? What kind of psychosocial interventions are being done, etc. So this is there are also other questions. Why, In recent days, Tamil Nadu State DMHP, PSW's educational qualifications are not equivalent, and none of the PSW is qualified according to the Mental Health Act. Whom can I write a letter regarding this? Of course, this only shows that large number of people have very actively participated, and that's very good. Before I request, I don't think there would be time to request the participants to make any comments, but the participants, the speakers' details are available. Any of the participants who want to contact the speakers can very well contact. I'll just make my 2 or 3 comments. Then I will request Dr. Alok Mathur to make some concluding comments, and finally hand over to Dr. Shekhar, who is not here in Nimans, who I believe is sitting somewhere in Chennai, to make the final concluding remarks and then close the session. I want to make only 3 comments. One is that, the title of a recent paper in the Lancet, which talked about non-communicable diseases and the burden of diseases, etc., was nations within a nation. I think the 4 presentations have shown us that. I was just looking at the population of the 4 states. Manipur has only a population of maybe about 25 or 30 lakhs. It's a small state. Karnataka and Gujarat are 6.3, 6.5 crores. And Chhattisgarh is about half of that. The kind of problems are very different. We heard very, very, interesting terms like artificial intelligence, the artificial intelligent tutor who tutors the nurse. And in a lighter vein, when Ajay Chauhan was talking about spirit, I was initially getting a little scared. He's speaking from Gujarat and he's speaking about spirit. I thought Gujarat, have they taken up the taken off the ban of alcohol? And then he clarified it is not spirit the way you and I understand it, is spirit in the suicide prevention program in Gujarat. We heard the excellent work that is being done in Chhattisgarh, which has now become the number 2 state in as far as suicide rates are concerned. So it's our country is actually nations within a nation. So no one size fits all. Each state has to have its own program. But what is most interesting is that there is a lot of transmission of knowledge. There is a percolation of knowledge. Manipur, the presenter mentioned Dr. Rajini's name and Dr. Ajay Chauhan's name. So also Chhattisgarh, which means that states which have better understanding, better experience are giving their knowledge to other states which don't have as much of expertise and knowledge, etc. This should go on. That is the way things will occur. Then, of course, I would again urge that all these 4 presentations, there is a lot of material, there's a lot of visual photographs, there's a qualitative information, there is quantitative information, not easily accessible to a lot of people. In fact, Dr. Sumi Jain, as a public health expert, already mentioned the point that not a lot of psychiatrists are interested in the district mental health program. Please, for speakers and the organizers, please work together to bring out a consolidated publication. You don't have to work too much. If you already have 4 excellent slide sets, put them together with little annotations, and that will be an excellent value addition to the knowledge base on district mental health program. So I would now request Dr. Alok Mathur, if he's around, to make some concluding comments. Your observations, I know that you had suggested many of the changes to the organizers for this DMHP program. And after that, I will request Dr. Shekhar to make the concluding remarks. Dr. Mathur, if you're around, please make some comments.
Yeah, thank you very much, Dr. Mohan. In fact, I would like to congratulate all the 4 speakers from the 4 states. In fact, Dr. Mohan, these program officers in different states in our country, whatever they are doing, that is giving me the strength here at the national level. So all the credit to them for implementing this program so wonderfully well in their respective states. So thank you so much for showcasing the activities, Dr. Chauhan, Dr. Rajni, Dr. Ranita, and Dr. Sumi. As you have said, they come from different regions of our country, and they are doing exceptionally well despite all the constraints, in the form of resources and all. And they are doing wonderfully well as far as I'm concerned. And they are giving me strength. In fact, when I sit at the national level, their work gives me strength. Thank you so much, all of you. And just a brief point about the rolling up of Ayushman Bharat CPHC, Comprehensive Primary Health Care. The component of Ayushman Bharat. As you know, the other component is of insurance coverage, that is PMJAY. Under the CPHC Ayushman Bharat, the government has a plan to upgrade 150,000 primary health centers and sub-centers throughout the country. And as you must have heard, different states have already started implementing MNS package. There is a special standalone package of MNS, mental, neurological, and substance abuse package under this CPHC Ayushman Bharat. And I hope that we should be able to roll out this package, successfully in the coming months. And we are in the process of training CHOs. CHOs means community health officers, multi-purpose workers, and ASHAs, so that they can understand their role at the CPH at the health and wellness center level as far as mental health is concerned. And we are very hopeful that we should be able to roll out this component of Ayushman Bharat, very successfully. And we have developed the operational guidelines also. We have developed the training manuals also, and hopefully we should be able to roll out this component also very successfully. So by that way, we would be covering, all the levels, right from district hospital level to taluka, CHC level, PHC, and subcenter. So for the first time, the mental health services, basic mental health services in the form of early detection, by screening these disorders, by providing promotion of mental health there, prevention services for mental illnesses, and timely referral, and then the follow-up. These kind of services would be organized and conducted at the health and wellness centers. So this would give us a big boost as far as implementing and providing basic mental health care services at the grassroots level, at the doorstep of the people there. So thank you so much. I think that's all from my side. Thank you.
Dr. Shekhar, we have been waiting to listen to you, Dr. Shekhar.
Good evening to everyone. It was featured by two great personalities, Dr. R.L. Kapoor from India, and then the person from WHO, who initiated this district mental health program way back in 1984 in the district. I remember his first presentation made on a OHP sheet showing a small triangle. This is a program with a technical input by NIMADS, along with the support of a district administrator and the director of health services. Was a sort of a thing what he started talking about the DMHP program way back in 84, 86, what I remember. And today's presentation, I'm seeing 318 persons sitting over and looking at a galaxy of stars in terms of presentation on the same DMHP. It was Dr. Mohan Isaac, Dr. CRC, Dr. R. Parthasarthi, Dr. Nagaraja, who are all there at the start of the DMHP program. And later we had the secretary at the district commissioner of Bellary, Dr. Makapur, the DHO, and then Dr. Murli, and later was a malaria officer, in fact, to be as the nodal person back in the district. And today seeing, as he rightly pointed out at some point of a time, that it started as a model program in one district, it went over to 7, it went over to 25, and the leadership of Alok Mathur now as a additional Deputy Director General Health Services, sitting back in the thing, we had the final words today that this program as a national program has covered almost all the districts in the country. That is the most heart welcoming sort of a thing what we have been talking in 1982, whether there will be this national mental health program will see any light of the day. Today has been given the statement, it is covering the entire country in terms of the larger aspect of it. All these national programs from our own field experiences, what we have seen, when it is getting implemented, as rightly pointed out by Dr. Mohan Isaac, are going to have issues pertaining to human resource, administrative issues, as well as issues pertaining to the service delivery. But what we need to appreciate is the type of service of making accessibility, availability, and affordability not only to the largest number of persons, but the type or spectrum of thing which is going to the needy person in the rural areas, remote rural areas, which means the program has achieved a larger objective, what it needs to talk about it. And so one of a chat I saw in the thing, why there is no antipsychotic medication available in one of the PHs. The similar sort of issue we also had, and me and Badri, Karur Badri Shah did a small activity at the instance of Dr. R. Srinivasa Murthy, and we looked at the budgetary provision and other thing. What we found against the number of the mentally ill given in a community, if you are pouring in all the money for the antipsychotic medication, still will be able to reach out only to 20% of the population. That was the point of a time back in 1990 on some cost analysis and all. But now when I go to various cities and other things, people are quite astonished to look at that there is a district mental health program. It is covering the entire nation and the way we are going about varied issues. Rather than taking much of a time, because we were supposed to close max, as earlier said, the last 2 minutes, let me consolidate with 3 issues. 1990, we had a Community Mental Health India under Indo-US Symposium, looking at both the places. Probably in another year or two, when the entire COVID situation comes out of it, we need to have a national conference of calling most of the state coordinators to come and talk about this particular issue of mental health program in the country. As one of the largest issue, a national conference to be thought about it. And he pointed out, earlier we were having one small little community mental health newsletter. But today, hearing this presentation, if a report on comparison between the north, south, east and the northeast sort of a thing is made, that would be one of the best sort of a contribution what we would be able to do as organizers of this program. And I feel that that should be done and given. And the type of issues will also make the Government of India ministry to look at it a little more in a positive manner and what are the other areas to be. And the largest sort of a change what I'm seeing is on the dashboard of e-Manas, which probably will get merged along with the MS package which is coming up. And that is going to open up the vistas of knowing that what are the ways and means the entire thing is going about in this particular country. So one is in terms of the service, monitoring through the e-Manas program. Another one is to record this particular thing and put it as a report and submit it to the ministry so that they look at this particular outcome of the thing and a few recommendations so that whatever the chat box information which has come, we should be able to put up those as some of the recommendations which is coming from this sort of work. And also we need to remember at this point of a time, in terms of the achievements, whatever has been made, when health becomes a state subject, again, the mental health also is one among that. We need to look at it. And post-graduation studies, especially in the mental health area, is much, much needed. Yesterday, in had a finance committee meeting back in Delhi. One of the larger thing what the secretary probably had articulated with the advisor is to look at manpower development at the post-graduation level in the area of health. So, other thing what we need to look at of any policy that is always to be created most of the time and all. So the unification policy has brought in some of the issues.
The last part of what you were saying, we missed you, Shekhar. I think there's some problem. And network.
Small technical problem.
On. Now we can hear you. Please go on.
So the is in terms of for the country postgraduate development of manpower in the field of mental health and it should soothe the type of issue.
I think we have missed you again. We are not able to see you or hear you.
Again, probably I need to complete it because the type of a signal is very, very poor here.
Okay.
With this sort of a words, I once again thank the Department of Psychiatric Social Work. Probably the Thanksgiving might be taken up by you because of the instability in the thing. I thank Professor Mohan Isaac for spending wonderful time along with us in this particular endeavor. Thank you very much.
Thank you. Thank you, Shekhar, for co-chairing this meeting. It's been a wonderful evening discussing about the district mental health program. There are a lot of people here in the audience, even physically, who I should have asked to speak. There is Dr. C.R. Chandrasekhar. We both have worked together for a long time in the initial days of district mental health program. There is Dr. Sharif, who was the head of the department. I remember him coming for the annual reviews to Bellary when we had the initial annual review of the district mental health program, because it started as a project of, as Shekhar said, NIMHANS and the district administration and the Department of Health and Family Welfare of Karnataka. But then the actual presentation by people were so interesting that we didn't have time for any great discussion. I want to thank all the 4 speakers who prepared excellent slides and presentations. All the people who actively participated by, interacting with the team through the chat box. And I want to end by thanking Dr. Pandian. Would you like to say anything? I will now give handover to the head of the Department of Psychiatric Social Work. I want to thank Dr. Pandian and Dr. Anish Cherian and many other people who organized this program for kindly inviting me to chair this program. Over to Pandian to make the final remarks and to conclude the meeting.
Thank you very much, sir. It's really a great opportunity for the Department of Psychiatric Social Work, NIMHANS, to organize this implementation of district mental health program in India in collaboration with the telemedicine unit of NIMHANS as well as the community psychiatry unit of the Department of Psychiatry of NIMHANS. It's really a great honor on behalf of the Department of Psychiatric Social Work and Department of Psychiatry and all the mental health division, the behavioral science division of NIMHANS. We are extremely thankful to Professor Mohan K. Isaac and Professor Dr. K. Shekhar for chairing the session and very beautifully conducted the entire process. We are extremely grateful to Dr. Alok Mathur, the additional DGG of Ministry of Health and Family Welfare, Government of India, for his keynote address. And we are extremely grateful to all the speakers, very especially Dr. Rajini Parthasarathi, the Deputy Director, Mental Health Division, and the Senior Coordinator of the District Mental Health Program of Karnataka. I think the word Parthasarathi always associated with the District Mental Health Program. Initially, Radhakrishnan Parthasarathi, Dr. Ranita Devi from Manipur, and Dr. Sulil Pandya from Uttar Pradesh for all their significant contribution to updating the various kind of services in the area of DMHP for the entire audience. I am extremely grateful to our director, Dr. G. Gururaj, our director of NIMHANS and registrar, Dr. Shankar Narayan Rao, all the HODs, very especially Professor Pratima Murthy, HOD Department of Psychiatry, Dr. Y.G. Janardhan Reddy, the in-charge HOD Department of Psychiatry today, who has helped us to organize this program very effectively today. And we are also grateful to all the HODs of the Department of Psychiatry, Psychology, Psychiatric Social Work, Psychiatric Nursing, Mental Health Education, and all other allied departments of NIMHANS, all the faculty members from all the departments of the Mental Health Division, and all the people who are on online. Today, it's more than 350 people through online and who are sustainably participating till today. Among the senior members, there are many members, including our Professor R. Srinivasamurthy, our senior professor of psychiatry and our former HOD and former dean of NIMHANS. Actually, I mean, he's with us. And because of and we are extremely grateful to Professor C.R. Chandrasekhar, our senior professor of psychiatry and former HOD of psychiatry, and the mentor for the entire Department of Psychiatric Social Work, and for all his vision and commitment. In fact, the professor has donated more than 1 crore rupee for initiating a geriatric mental health services at NIMHANS. We don't have words. The entire NIMHANS, all the students and all the staff members, we are extremely grateful to Professor C.R. Chandrasekhar, not only for his commitment, sincerity, and empowering the entire mental health division of NIMHANS and many other trainees all over the world. We are extremely thankful to Professor C.R. Chandrasekhar. I am very privileged to have all my professors with me today. Professor Dr. I.A. Sharif, our founder professor, Dr. M. Ranganathan, Professor of Psychiatric Social Work and founder of the Family Fellowship Society for Psychosocial Rehabilitation, Dr. D. Muralidhar, our Professor of Psychiatric Social Work, former HOD, and the person who worked for the welfare of the chronic schizophrenic patients through various other means, including area of addiction. And many other professors from various departments also have participated in this program. Very especially, I am thankful to Professor A. Trimurthy, Professor of Psychiatric Social Work and former HOD, and presently working very actively in the along with the adult psychiatric unit. Dr. Trimurthy also actively working in the area of geriatric psychiatry, along with the Dr. P.T. Sivakumar and Professor Matthew Verghese and the entire team. And they are initiating many other activities, and all their participations are extremely grateful. There are many other international participants. For example, I could notice some of them. Andrei Ganguly from WHO India office, Dr. Sumir Jain from the University of Edinburgh, Ms. Petra Graham from the King's College London, Dr. Sonia Diori from LGP, and Dr. Karan Mitra from New Zealand, and many other senior people. And I could see many of the alumni of NIMHANS from all over the world. So it's a great opportunity to meet all of them. On behalf of the organizing committee, we are extremely thankful to each and every one of them who have participated in this program today. I once again grateful to our beloved Professor Mohan K. Isaac, and who is a chairperson for today, and Dr. Rajini Parthasarathi, our Deputy Director of Mental Health. On behalf of the organizing team, I request our senior professors to kindly felicitate Professor Mohan K. Isaac and Professor Rajini Parthasarathi and and our other senior members. Just 1 minute we will take, sir. Please, get the chair. You get down. Yes, sir. We'll do it, sir. You bring the chair. And the chair. I request Professor Dr. C.R. Chandrasekhar, Professor Dr. Sharif, Dr. Ranganathan, Dr. Muralidhar, Dr. Trimurthy, Dr. P.T. Sivakumar, please kindly forward to felicitate our professor. Sir, please come. Sir. Just 1 minute, sir. Will not take much time, sir. Please come, sir. Please come, sir. I request all our professors to kindly felicitate our professor. I request Dr. Rajini Bhattacharjee, our division of Karnataka and the primary coordinator for the Karnataka district program. I request Dr. P. Nirmala, please come, please. Dr. Parsha Nirmala, yes, yes. Please, ma'am. About 4 pieces. Person, problem, process, and so where are the 3 pieces? Thank you very much, madam. I request Professor Dr. C.R. Chandrasekhar. So I have the honor Dr. Greece there, our Professor of Entrepreneurship, Institute of Entrepreneurship, our mentor. I also request Professor Sharif, who received the deal yesterday after 3 years. Oh, yeah. Please, please. Yeah, yeah, please. Thank you, sir. Please. Thank you.
Sir. Okay. Yes. Okay. So it's been, as I said earlier, a wonderful evening. Thank you very much, all of you who have actively participated. I think it has gone on reasonably well, although people were in different places, Manipur, Chhattisgarh, Gujarat, Delhi, Chennai, etc., as also the large number of participants from within the country. The alumni, very distinguished alumni of the Department of Social Work, as well as other alumni of NIMHANS. Dr. Shekhar, who is a registrar, he recently completed his 5-year term as registrar of NIMHANS. And it's been wonderful to review the district mental health program. As Shekhar highlighted, we need to have a national level review of what's happening, where, as Dr. Sai Kumar has highlighted, we should not just be patting our back, but really look into what exactly needs to be done in terms of outcome for patients, etc. And then lastly, I think it is a job of the organizers, headed by Dr. Pandian, that some kind of proceedings of this, there have been a lot of material presented by the distinguished speakers who all talked about what is happening in their own states. I think technology has in a way advanced our work because there is tele-mentoring, consultations, etc. And we heard the word artificial intelligence and data analysis, mass data analysis. We can learn from all these things. So we hope to see the proceedings from this, district mental health program implementation. We also had the key person at the center, the Dr. Alok Mathur, participate in this. So I want to conclude this online program by thanking everybody. And let's hope that we'll be again able to meet on a similar platform or face-to-face in future, looking at what's happening in the district mental health program. Thank you very much.